Teka, pa-message na lang sa sa Viber natin. Okay, good evening everyone. So we will start with our prayer. So let's place ourselves in the presence of the Lord. So in the name of the Father, the Son, the Holy Spirit, Amen. Dear Almighty and ever-loving God, we glorify and thank you. You have showered us with so much blessings. Your presence continuously reminds us of your faithfulness and guidance. We humbly ask you to shower our speakers today of your greatest inspiration so that they may share the most of their knowledge, heart and soul to their respective topic. May we absorb the invaluable knowledge and put it into practice what we may learn today. We pray that you bless all the committees in charge, that they may be able to fulfill their tasks responsibly, that the objectives that they have set may all be achieved. Your infinite blessing would mean the success of this activity. May we be living witnesses of your genuine love through the enactment of the knowledge acquired through this activity. We ask this in the name of our Lord and Savior. Amen. Next, Lynn. Yeah. So, habang hinihintay natin yung slide, kanang audio.
To keep abreast of the most recent developments in all fields of diabetes research, education, and treatment. The PSD Statement of Purpose. The purpose of PSD is to give persons with diabetes lives with qualities unaffected by the condition. This is their right more than a privilege. This passion sustains and empowers us to find meaning and fulfillment. The purpose of PSD is to understand and accept that diabetes is a complex condition affecting an individual, the family, and community. Knowledge of its biomolecular and cellular origins and understanding all its interventions are as important as mastering its psychosocial dynamics. The purpose of PSD is to be a family of responsible persons bonded by one passion. Agreeing and disagreements strengthen our unity. Criticisms fuel our growth. Love fills our camaraderie. The purpose of PSD is to be a source of inspiration that informs, guides, and corrects one another in daily practice. We find happiness in sharing knowledge and experiences that improve patient lives. The purpose of PSD is support individuals and organizations with similar noble goals, acknowledging that we all live in one world and fighting diabetes together multiplies good outcomes with a fraction of effort. Collaboration drives inspiration, motivation, and creativity. The purpose of PSD is to welcome the cure. When diabetes no longer exists, we will reincarnate with new passion and direction. Our vision will evolve with time, but the family lives on.
So for our attendants, please type your name sa ating chat box po ha. So to continue, Dean.
Naglalag ata si Lynn.
Naglag po eh. Wait lang po.
Sige. Nag-practice naman tayo. Ganun talaga pag live. So habang hinihintay po natin ha. So please type your name sa ating pong chat box for our attendance. And hopefully, maka-join yung ating speaker, si Dr. Solante, for if you have any questions or clarifications with regards to the lecture. Okay, so I'd like again to introduce to you our PSD Board of Directors. Yours truly is the President. We have Dr. Marcy Cruz, our Vice President, Dr. Fatma Chu, our Secretary, and Dr. Jamin Agra, our Treasurer, and our Auditor, Dr. Rakit Tison. So we would like to welcome you to our PSD Selected Lectures 4. So yung pandemic is still here by COVID-19, so it affected mostly our patients. So the board has taken this opportunity to enhance our knowledge in pursuit of excellence in diabetology during this time. So in line with this, we already have the 4th special edition lectures of your PSD. So these are a series of virtual lectures to keep our alumni abreast of the information in diabetes. So the objective of the series 4 is to discuss the updates in diabetes, obesity, nutrition, and COVID-19. So our program for today or for our tonight will be a pharmacy ME grant from OEP. And this is the risk-benefit ratio of this lipidemia treatment in the multiple risk population. So are Asians different? And the speaker will be introduced later is Dr. Lourdes Ella Santos. This will be followed by a talk of Dr. Ron Jean Solante on where are we now in the battle against COVID-19. Next. So we would like again to thank Orient Europharma or OEP for this pharmacy ME grant. And they are the makers of your pitabastatin and Pitator. So we would like to call the Vice President of OEP, Sir Flo Uy.
Hi, good evening, Dr. Baltimore. Welcome everyone. Welcome to this evening's PSD 4th Special Edition lecture. I'm Florencio Uy, and on behalf of OEP, we would like to extend our heartfelt appreciation to the PSD board and to all its members. Just as a backgrounder, it was around 2018 when Orient Europharma or OEP introduced to the Philippines an original Japanese R&D molecule in pitabastatin. At the time, it was Pitator 2 milligrams. Since then, we are very happy to report that OEP has helped more than around 200,000 Filipino patients. And this has happened because of the trust you gave to OEP and to Pitator 2 milligrams. With that, we say thank you very much for the support. Tonight, we are happy to note that OEP will introduce the higher dose of pitabastatin. We're going to introduce Pitator 4 milligrams. And from the lecture tonight, we're happy to share the robust evidence of Pitator 4 milligrams cardiovascular protection for multiple risk Asian patients and among Asian patients with chronic coronary syndrome or stable CAG. Again, we'd like to thank PSD. We'd like to thank Dr. Santos. We'd like also to thank Dr. Solante for sharing your knowledge. And of course, to the PSD for allowing OEP to sponsor this CME grant. Again, thank you very much, and let's enjoy tonight's evening's activity.
Thank you very much, Sir Flo.
Thank you.
Okay, siguro naaalala nyo pa siya, no? Kung siguro hindi nyo yan makakalimutan kasi siya po yung isa sa mga napakabait na mga boss previously from the other company. Pero hanggang ngayon siguro napakabait pa rin yan. Kaya we would like again to thank OEP for this support on our lectures. Okay? Thank you, Sir Flo.
Sure.
And I'll introduce our speaker. So for the first part of our lecture is an associate clinical professor of the UP College of Medicine, UP Philippine General Hospital. She is a fellow of the Philippine College of Physicians as well as the Philippine College of Cardiology and Philippine Heart Association. At present, she is the president of Philippine Lipid and Atherosclerosis Society. She is the head of the Technical Research Committee of the 2020 Clinical Practice Guidelines for the Management of Dyslipidemia in the Philippines. So friends, I'd like to give you Dr. Lourdes Ella Santos.
Thank you for that kind introduction. Without further ado, let me go ahead and share my slides. So we're very excited to talk tonight about a topic looking at the risk-benefit ratio of dyslipidemia treatment in the multiple risks population, particularly zeroing in on the question of differences racially. Are Asians different? So this is the outline. First, we'll define multiple risks population through clinical cases in primary prevention, what the guidelines say, identifying plasma lipid disorders in Asia and the lipid goals that are different between Asian and Western countries, particularly zeroing in on a molecule called pitavastatin and its robust evidence for landmark trials in Asian populations, and showing it as an optimal balance between efficacy and safety in patients with multiple risks. So let's begin with primary prevention. This is our clinical case. A 59-year-old male with a 10-pack year smoking history, no premature history of cardiovascular disease. His blood pressure is elevated at 150/90 with a BMI that is obese based on the WHO Asian criteria. His lab findings show that he has insulin resistance with an FBS of 119 and a hemoglobin A1C of 6.3. If you take a look at his dyslipidemia, we see that his total cholesterol is elevated. It should be less than 200. Triglycerides are elevated. It should be less than 150. An LDL that is high, it should be less than 130 in primary prevention, and an HDL that is low, which should be more than 40 in men. So when we take a look at the 2020 clinical practice guidelines for the management of dyslipidemia in the Philippines, understand that we identified several risk factors. And these are male sex, postmenopausal women, smokers, hypertensives, those with a BMI of more than 25, a family history of premature coronary heart disease. Of course, this is alluding to familial hypercholesterolemia, microalbuminuria, proteinuria, and left ventricular hypertrophy. So if we take a look at our clinical case, we see that he has several risk factors on top of his dyslipidemia. He's male, he has a smoking history, he is hypertensive, and his BMI is more than 25 kilograms per meter squared. Understand that when we talk about these guidelines, unfortunately, we have no local risk scoring. There are several Framingham cohort studies we're looking at here in the Philippines, where we hope that after following them up for 8 to 10 years, we can come up with our own ASCVD risk calculator. However, in the absence of a calculator, we as a group advocate risk factor counting to be able to estimate the level of risk for cardiovascular events in Filipino dyslipidemic patients. So the ACCHA has an ASCVD risk calculator. This is free, available online, where you just have to plug in values to be able to calculate the 10-year risk of heart disease or stroke in your patients. Unfortunately, this ACCHA calculator has not been validated in the Asian setting. Understand that the role of this ASCVD risk calculator is that it comes up with a percentage where if the 10-year risk for developing stroke or heart attack is more than 7.5% in primary prevention patients, once you input the data, there is a push to start these patients on statin therapy because they will benefit from it based on their cardiovascular risk. Of course, those patients that score higher, more than 20%, are labeled as high-risk individuals where statin therapy should be started. So again, the limitation to this ASCVD risk estimator is the fact that it can under or overestimate the 10-year lifetime risk in Asian Americans. So it hasn't been validated yet in the Asian region as a calculator. And this is the reason why it's important to be able to come up with our own calculator. When we take a look at Southeast Asian countries, you will appreciate that the cardiovascular risk scoring system is different per country, where they're trying to validate their own score scale. So in Indonesia, they have their own score scale, the Jakarta Cardiovascular Score. In Malaysia, they use the CV risk scores of the Framingham General. In Thailand, they have their own Thai CV risk score, and in Vietnam. So again, there is an urgent need to be able to come up with our own calculator, and we are looking forward to seeing our data so that we can publish our own CV risk scoring. In the meantime, again, looking at patients with multiple risks, it's really just counting risk factors to identify those at higher risk. So in our primary prevention statement for non-diabetic individuals, if they fulfill the 3 criteria, that is age more than 45 years, an LDL more than 130, and 2 or more risk factors, then these patients should be started on statin therapy. So again, here we have multiple risks where 2 or more risk factors have been identified in our clinical case. We see that he is more than 45 years and his LDL is more than 130. So our patient fulfills the 3 criteria to be started on statin therapy in primary prevention. So if we take a look at the algorithm for our local guidelines, here we have a patient with an LDL of more than 130, age of more than 45, and 2 or more risk factors, then this patient should be started on statin therapy. The goal for this particular patient is when we look at those individuals with no clinical ASCVD to target an LDL cholesterol of less than 130 milligrams per deciliter. So in our patient whose LDL is 145 milligrams per deciliter, we want to be able to bring it down to less than 130 milligrams per deciliter. And we have actually provided in the Philippine Clinical Practice Guidelines 2020, statin treatment intensity, where we've identified statins with the amount of % reduction they can confer depending on the dose. In this particular case, we'd like you to consider treating this patient with a moderate intensity statin therapy using pitavastatin 2 milligrams to be able to get your patient to that goal LDL of less than 130 milligrams per deciliter. So the next case that we'll be talking about, of course, is a patient with diabetes with multiple risk factors. So looking at that particular case that we had seen earlier, now with a fasting blood sugar of 129 and a hemoglobin A1C of 6.8, fulfilling the criteria of diabetes, if this was the clinical scenario that this 59-year-old male presented with, in our local guidelines, the recommendation for diabetic individuals without evidence of atherosclerotic cardiovascular disease is to routinely give statin therapy to prevent cardiovascular events. And I know you guys have seen this slide over and over again, but it is really just to review us on the atherogenic dyslipidemia in insulin resistance to understand why the recommendation, and we are the only Asian guidelines that recommends all patients with type 2 diabetes be placed on statin therapy. Because pathophysiologically, if you have a patient with insulin resistance, understand that these patients produce a lot of free fatty acids in the endogenous system. These free fatty acids result in an increased production of very low density lipoprotein. Understand that these very low density lipoprotein, when triglycerides are removed from these big buoyant particles, they become smaller, more compact molecules called intermediate density lipoprotein. As more triglycerides are removed from these intermediate density lipoprotein, they become more compact even into low density lipoprotein. Now, what happens, as we all know, in patients with insulin resistance or diabetes is the fact that their pathway doesn't stop at LDL cholesterol. More triglycerides get removed from it because lipoprotein lipase gets very excited in the presence of high sugars that it continues to remove triglycerides from even LDL cholesterol, forming smaller, denser LDL cholesterol. And these smaller, denser LDL cholesterol are really very pro-atherogenic because instead of being LDL, which are bigger in size, they become even more compact, smaller, and denser. So, aside from small, dense LDL cholesterol that is seen in patients with atherogenic dyslipidemia, we know that these patients actually have low HDL cholesterol. And again, we understand that these HDL cholesterol molecules, for them to be stable, they need ApoA1 on their surface. Unfortunately, in the presence of high sugars in the body, an enzyme called hepatic lipase gets so excited that it removes ApoA1 from the surface of HDL molecules. When ApoA1 is removed from the surface of HDL molecules, these HDL molecules become unstable and they go back to becoming more VLDL in the reverse cholesterol transport. So, because more VLDL cholesterol is formed in the presence of unstable HDL when there is high sugars in the body, then this VLDL produces more IDL, more LDL, and more small dense LDL cholesterol. And this is the reason why in your patients with diabetes, the treatment for their low HDL is not to give them more HDL in the form of omega fatty acids. You have to treat their sugars because as long as you can treat or give better glycemic control, then hepatic lipase will not remove ApoA1, will stabilize their HDL because remember that these patients do not have low HDL, they have unstable ones. So don't supplement them with omega fatty acids because in essence, if you do and you don't treat glycemic control, then all you're doing is increasing their unstable HDL, which contributes to more VLDL, producing smaller, denser LDL cholesterol. So again, in patients with diabetes or insulin resistance, we see really that these patients have high triglycerides, low HDL cholesterol, near normal LDL cholesterol because their LDL doesn't stop, their pathway doesn't stop at LDL, but then produces more small dense LDL cholesterol. And this is what makes our patients with diabetes more pro-atherogenic. Because understand that this small dense LDL cholesterol, just to place it into perspective, it exhibits increased vascular permeability. So if you take a look at the mean endothelial pore size, so understand these small dense LDL can insinuate through the subendothelial lining and deposit in the vascular wall. So if you take a look at these dense LDL, the smaller ones, compared to your buoyant LDLs that are still filled with triglycerides, the pore size can go through much easier with a smaller, denser LDL. And that's why they're more pro-atherogenic. What else is different about small dense LDL cholesterol is that they're more susceptible to oxidation because they stay longer in plasma for about 5 days, So that gives them more time to get exposed to oxidation. So infiltration and retention of small dense LDL is a critical initiating event that sparks an inflammatory response when these small dense LDL insinuate through the endothelium, develop atherosclerotic plaques and foam cells. So it actually triggers atheroma formation. So these small dense LDL particles can insinuate through the subendothelial lining. It triggers that cascade where macrophages can eat up the small dense LDL cholesterol, form foam cell formation, and develop your atherosclerotic plaque. So these smaller LDL particles are more pro-atherogenic than the larger cholesterol-enriched ApoB particles. So just to place it again into perspective, understand that when we talk about LDL cholesterol, these small, dense LDL cholesterol are subfractions of LDL cholesterol. And what's scary about it is when you take a look at LDL cholesterol, understand that two patients with exactly the same LDL cholesterol, one patient with LDL of about 130 and another patient with LDL of about 130, if you take a look at those particles and you count it, those patients with larger LDL compared to smaller LDL, those patients with smaller LDL with the same LDL number, but with smaller LDL cholesterol actually have higher proatherogenicity because each one of these particles can actually insinuate through the subendothelial lining compared to those patients with larger LDL where they have a lower predisposition for insinuating through the subendothelial lining. So what I want you to appreciate here is, although we have no way to measure small, dense LDL cholesterol yet, there are several trials ongoing. When you take a look at these small, dense LDL cholesterol, understand that on the surface of every one small, dense LDL cholesterol is one ApoB molecule. So on its surface, for every one small dense LDL is an ApoB molecule. In essence, if we count the number of ApoB molecules in the body, it is a better surrogate of counting the proatherogenicity because it allows us to define small dense LDL over larger LDL, where those patients with smaller denser LDL will have greater number of ApoB compared to those with large LDL, despite the fact that their LDL numbers are the same. So the greater the particles, the greater the ApoB number, the greater the number of particles that can insinuate through the subendothelial lining and cause proatherogenicity. So ApoB, unfortunately, there are few centers in Manila that can actually measure ApoB. So in Cardinal Santos Medical Center, where I work, ApoB is actually now available and we use it as a risk-enhancing factor in our patients whose LDL cholesterol goal has already been achieved. So going back to our clinical case, because our patient has type 2 diabetes, the recommendation is to start statin therapy immediately. Again, regardless of that LDL cholesterol level. So when we take a look at the goals for patients with LDL cholesterol with diabetes, you see that in patients with diabetes, we've actually classified them into those with risk factors and with ASCVD. So if the patient just has diabetes, the LDL cholesterol goal is less than 100. If you've identified more than one risk factor or target organ damage, then the LDL cholesterol gets pushed to below 70 milligrams milligrams per deciliter. And in those with ASCVD, a more aggressive LDL target of less than 55 milligrams per deciliter. So going back to our patient whose LDL cholesterol is 145, where our goal LDL for him is less than 70 because he has several risk factors, we would like you to consider starting this patient on moderate intensity statin therapy, particularly pitavastatin 4 milligrams. When we talk about the triad of atherogenic dyslipidemia, I'd like you to realize that in these patients with type 2 diabetes, and you frequently see these patients with elevated triglyceride levels, we've talked about diminished HDL levels. These elevated triglyceride levels should not be treated primarily. It is still LDL cholesterol that should be targeted. And the reason why is because, for example, in this particular patient with triglycerides of 167, understand that the ACCORD lipid trial showed that in those patients who were in the background of statin therapy, there is no evidence for translation into cardiovascular disease if you administer fibrate routinely on top of statin therapy in patients with type 2 diabetes. More than that, when you treat patients with statin therapy, understand that you get a significant triglyceride reduction of about 7 to 30%. So by treating the small, dense LDL cholesterol with statin therapy, you're also reducing their triglycerides by 7 to 30%. In the LIVE study, which was a post-marketing surveillance study of pitavastatin, again, among Asians, so these were Japanese patients, they found that these patients had a significant reduction in their triglycerides when pitavastatin was given to them. These patients had about 22% reduction in triglycerides when pitavastatin was administered, looking at these patients who also had type 2 diabetes. So we go by the NCEP guidelines that in patients with triglycerides that are 200 to 499, the primary objective is still LDL cholesterol goal lowering, with a secondary objective of non-HDL lowering. And non-HDL is always computed as total cholesterol minus HDL cholesterol, 30 points above your LDL cholesterol goal. It is only when triglycerides are above 500 that the primary objective be triglyceride reduction, and only because you want to prevent these patients from developing pancreatitis. So going now to the difference, when we talk about Asians, is the dyslipidemia different? Let's take a look at pharmacokinetic studies on statin therapy. This was exposure to statin and its metabolites, and this was found that in Asian populations residing in the US compared with Caucasian subjects, those patients who were exposed to the same number, same dosage of statin therapy, those Filipino Asians actually had a higher statin metabolite when compared to the Caucasian counterparts. And this racial difference was actually also seen in a meta-analysis of 20 statin clinical trials, that Asians, particularly those compared to their Western counterparts, had a lower dosage need of statin therapy with a lower intensity LDL cholesterol lowering to be able to reach their goal compared to Westerners. So that if you take a look at the dosages that are available in Japan, which is very sensitive to the dosing of statin therapy, we see that the maximum doses in Japan of several statins are actually much lower than those that are available in the US. Japan actually even has a rosuvastatin 1 milligram tablet because they know that the Japanese are very sensitive to statin therapy. And this was identified in the 2018 ACC-AHA guideline where, for clinical decision-making in adults, it is reasonable for clinicians to review race or ethnic features. So let's zero in on plasma lipid disorders in Asia. The CRISP, or Cardiovascular Risk Prevention in Asia Network, looked at age-standardized death rates per 100,000 for cardiovascular disease. If you take a look at the Philippines, we do see that the rate of death from cardiovascular disease still ranks as one of the highest. And when they identified cardiovascular disease burden attributable to modifiable risk factors, comparing them, we do see that high LDL cholesterol still remains, dyslipidemia still remains to be a contributory risk factor when we're talking about cardiovascular disease. Now, when we zero in on particular components of the lipid profile, we see that LDL cholesterol among those in the Philippines, according to our National Nutrition Survey, still ranks high with low HDL as one of the commonalities. Understand that in the world, there are very few countries that have low HDL cholesterol, and the Philippines is one of them. So when we talk about particular molecules that can treat Asians, we know that pitavastatin has robust data in the Asian population. Pitavastatin is one of the newer drugs, one of the newer statins that have come out. Its indication is for primary hyperlipidemia and mixed dyslipidemia. You see that the bioavailability is high with great protein binding, and because it has a 12-hour half-life, it is great for its dosing for once a day. The pathway that is used by pitavastatin is a specific one for glucuronidation, which tells us that because it doesn't go through the cytochrome pathway, it has lesser drug-drug interactions. When we look to the equivalence, the therapeutic equivalence of statin therapy, pitavastatin at 2 milligrams can lower LDL cholesterol by 42% and 4 milligrams by 47%, placing it as moderate intensity statin therapy. In a comparative lipid-lowering efficacy of about 7 statins in network meta-analysis, it ranked third in lowering LDL cholesterol after our high-intensity statin, rosuvastatin, and atorvastatin. So it's great to know that pitavastatin does the LDL cholesterol lowering, particularly in Asian populations. But does it translate into cardiovascular outcomes? So TOHO-LIP was a head-to-head comparison of pitavastatin and atorvastatin. These patients, Asian patients, were randomized to pitavastatin 2 milligrams and atorvastatin 10 milligrams and followed up after 5 years. You see that similar LDL cholesterol, HDL cholesterol, total cholesterol, and non-HDL cholesterol impacted for both with their dosages. But the difference was that pitavastatin reduced C-reactive protein levels after 1 year. We know that C-reactive is an inflammatory marker which can detect atherosclerosis in patients, particularly those with higher plaque burden. And what was significant about this particular study is that despite the fact that both statins reached the same LDL cholesterol reduction, there was a significant reduction in cardiovascular events using pitavastatin in these Asian patients with hypercholesterolemia. And one of the reasons why probably there was a translation into cardiovascular events is because several studies have now seen the effect of pitavastatin on plaque regression and stabilization. So this is an optical coherence tomography that we used for coronary imaging. This is a non-invasive technique that actually shows high-resolution intracoronary images. It's very similar to the intravascular ultrasound. And usually what it does is it shows atherosclerotic plaque assessment. Now, they use this optical coherence tomography to be able to look at plaques in those patients who have been placed on pitavastatin. And this was the ESCORT study, which looked at higher risk individuals randomized to early statin group. So these patients were on pitavastatin 4 milligrams early on or later on after successful PCI. And just to be able to show significant LDL cholesterol lowering in these particular patients, but very similar for those who were in the early and late group. The early therapy with pitavastatin provided a significant increase in fibrous cap thickness. Understand that the thicker the fibrous cap, the more stable the plaque is. And this was conferred at as early as 3-week follow-up. So if you take a look at the early statin group, looking at the fibrous cap, you see very significant thickening of that fibrous cap compared to those who were later started on with statin therapy. So pitavastatin, more exposure to pitavastatin gives a pleiotropic effect on plaque stabilization. So Dr. Barter, one of the gods in lipidology, claimed that pitavastatin has very protective properties that may not be shared just by their LDL lowering therapies, showing a mortality benefit for aggressive statin therapy. And this was also reflected in the real CAD study, looking at high-risk individuals with stable CAD who were randomized to pitavastatin 1 milligram and 4 milligrams per day. You see that these patients had significant LDL cholesterol lowering, triglyceride lowering, HSCRP lowering in the more aggressive, higher dose pitavastatin. But what was even more significant was that on top of those patients who were on 1 milligram, the 4 milligram pitavastatin had greater cumulative reduction in primary endpoints, CV death, MI, ischemic stroke, and unstable angina. They conferred a 19% lesser risk of cardiovascular events. And one of the reasons why pitavastatin is significant in the Asian population, understand that all of these clinical trials were conducted in the Asian population, even the cardiovascular outcome study, is that it has a unique metabolism in that it undergoes glucuronidation as opposed to cytochrome P2C9 of fluvastatin and rosuvastatin and cytochrome P3A4 of atorvastatin and simvastatin. Remember that a lot of drugs are excreted and through cytochrome P system. So because pitavastatin has its own pathway through glucuronidation, it has a lower risk of drug interaction and adverse drug events. So the safety outcomes, which seems to always be a concern in Asian patients, is the fact that if we take a look at pitavastatin, it shows a lower risk of increasing liver enzymes compared with other statins that use the cytochrome P450 enzymes. And this was seen in the CHIBA study. The CHIBA study also looked at Asian patients, and this seems to be a growing concern where in the 2020 guidelines, we've written some recommendations in patients not to discontinue their statin therapy unless the AST/ALT is above 3 to 5 times upper limit of normal when statin therapy has been started. In the real CAD safety outcomes that I showed you, which was a cardiovascular outcome study, pitavastatin 4 milligrams was very well tolerated with no significant difference in terms of rhabdomyolysis, liver and muscle enzymes, and new onset diabetes. Understand that this compared a lower dose versus a higher dose, and there was no significant difference between the two. So even higher dosing pitavastatin confers significant safety. Lastly, there's always an issue about new onset diabetes. This was seen in the Jupiter trial using rosuvastatin. When they looked at pitavastatin, it showed significant lower incidence of new onset diabetes compared to other highly potent statin therapies, atorva and rosuvastatin, telling us that pitavastatin can confer significant advantage in new onset diabetes mellitus. So in summary, individuals with multiple risk factors confer greater cardiovascular risk. There are racial differences in the response to statins between Asians and Westerners. The Philippines has a high prevalence of plasma lipid disorders within the Asia and Pacific region. Pitavastatin has numerous trials in Asian populations, showing benefit for CV protection and translation to outcomes. Because these trials are in the Asian population, then of course, the acceptability among Filipinos becomes higher. Pitavastatin should be considered in the armamentarium of lipid-lowering therapies among the Asian population with robust data showing its benefit for our racial ethnicity, particularly in those high-risk individuals with multiple risk factors. Thank you for listening.
Okay, so thank you very much, Dr. Santos, for that very wonderful and excellent lecture. She made the dyslipidemia in diabetes very simple, especially with the treatment of your pitavastatin among Asian population. Okay, so to continue, we would have our next speaker. He is the incumbent secretary of the PCP Board of Regents, a medical specialist of San Lazaro Hospital, an assistant clinical professor of the Department of Medicine at the UERMMC. Presently, he is the chair of the infectious diseases section of the UERMMC, the section of infectious disease and committee on infection control of the Manila Medical Center in Manila, and the section of and also of Adventist Medical Center, Manila. He is the chair also of the Adult Infectious Disease and Tropical Medicine Fellowship Program of the San Lazaro Hospital. He is the past president of the Philippine Society of Microbiology and Infectious Diseases and the Council of Advisors of PSMID. So without further ado, let's all hear Dr. Solante on this topic on COVID-19.
Good afternoon. And first of all, I would like to thank for this invitation and to discuss this topic on where are we now in the battle against COVID-19. So these are my disclaimer, part of the vaccine expert panel and also for the FDA and also part of the technical working group of healthcare facility development program in infectious diseases. So the scope of discussion will focus on where are we now and as we move along with this pandemic, what are the imperatives that we have to deal with this what you call new normal. So this is the latest from the WHO as of March 18. There are already around 464 million plus confirmed cases, and that also included 6 million deaths. But as of March 17, this is the total number of doses that has been given to the population, and it's more or less 10 billion doses plus. And that's something that we're looking forward because we deemed it very important that the vaccine still form an important part of bringing us back to normal. So as of this date, March 19, 2022, a lot of countries are already reporting normal or negative growth in terms of number of cases, and positivity rate has been going down, except for some countries, especially in some Asian countries like South Korea, Vietnam, Singapore, and even Malaysia and Indonesia are still reporting increasing in the cases. Okay, and if you look at here where the Philippines belong, so the Philippines is really here, almost less than 1,000 of cases a day. And comparing ourselves with these Asian countries in terms of the reported cases in the last 7 days, we are one of those countries. Okay, we're better than Malaysia, better than Indonesia, better than Japan, Vietnam, and South Korea, where in some of these countries already have a higher number of fully vaccinated population. Like for example, in South Korea, their fully vaccinated population is already around 86% compared to the Philippines, which is only around 58%. And then compare it with Australia, which is also around 80%. Thailand has already 71%, and yet their cases are still going up. And it means that there's a possibility that the Philippines will also experience this increase in the cases as we are into this stage of the infection. So it's not a guarantee that for now we only have around 3,721 for the last 7 days. But again, that's not a guarantee that the pandemic will end. So what are the imperatives? What should be done and what should we be doing? Okay. So there are still a lot of questions that we have to answer. And in this latest increase in the cases, okay, we are already talking about how to adapt, okay, to this infection. We know that there is always a possibility that immunity will wane with vaccination, and the possibility of also cases that will be causing spikes and surge. But we just can't be doing lockdowns because that will really impact on our economy. And the question then is how effective are vaccines in decreasing the spread of SARS-CoV-2? As you know, countries with very high vaccination rate, and yet there are still surge and spike that were occurring. So very important here is we have to track the progress. We need to have our own capability to track the emerging variants. We need to expand capacity of laboratory to do genomic surveillance. And this is important since we know that variants of concern will persist and will continue to be a threat in causing this prolonged pandemic. And if we look at the frequencies of variants of concern over time, you notice that this is how effective this variant can change, can mutate, and and with that mutation can cause more transmissibility, and in fact can also cause higher death, no, as we have experienced with Delta. So from the start of the pandemic up to this January, we have known almost 7 major mutations that affected the surge in cases, and we continue to have the cases. Okay. So currently, the most dominant variant of concern now is your Omicron variant, and specifically, it's your BA2. Your BA2 is also the variant of concern that's the most common now in the Philippines. So what are the implications here? BA2 is more transmissible than BA1. And that's why countries like Asian countries and some European countries are reporting resurgence of the cases because of the BA2. And BA2 can also affect the effectiveness of our vaccine. Okay? As we look at some of these vaccines, if we give the third dose, it retained its ability to protect us against the BA1 and that of BA2, but the prospect of a waning immunity 12 weeks after the third dose is always a possibility that when we look at the lower vaccine efficacy afterwards, then chances that are there, these are the more important reason why some countries now with a high number of population that are vaccinated is experiencing this resurgence of COVID. So tracking the progress will also allow us to still continue to activate or to put some what we call metrics so that we will know how far or how are we doing with our restrictions. Okay, and that's why if you'll notice we have the alert level system, and this alert level system is dependent on the reproduction number, the average daily attack rate, the positivity rate, including healthcare utilization rate. So in a way, the government should continue to monitor these metrics in order for us to know what is the current status, and are we going to tighten public health policies? Are we going to activate more stringent alert level system? Just to give you an example on how the government based the alert level system, these are based on these metrics, and there are threshold of these metrics that will allow us to classify if we are in the very low, to low risk, to moderate, high, very high, and severe risk. Okay, so at the moment, most of these regions are already in the very low risk of COVID-19, and these are based on these metrics. Second is after targeting, we need to have targets. We need also to limit illness and death. Okay, so we've learned a lot that vaccine can protect us against getting the infection, but it also has a higher purpose and higher benefit, which is protecting us against severe cases of COVID, which is critical in normalizing the society. Okay, so this is the current vaccinated population in the Philippines, and there are still regions with a low vaccination rate, but I hope the ramping up of the vaccination campaign will also involve engaging some of these regions wherein the vaccination uptake is very low. So vaccine has saved us in terms of producing and complication of severe illness, especially with the Omicron variant. No? So from a Delta variant to an Omicron variant, which significantly affect the ability of our vaccines to protect us. But with the third dose, you'll notice that efficacy has been sustained, protecting us against severe illness and protecting also us against hospitalization. So that's precisely why we need a third dose, because getting a third dose will protect us more than just getting the primary vaccine series. And in fact, this is the data coming from the US that among vaccinated individual, comparing it with vaccinated, you have 23 times higher to be hospitalized. No? This is coming from the US. And if you are also boosted, then you have a lower risk of getting hospitalized compared to those who only receive primary vaccine series. So that's what the government is doing now, encouraging particularly the A2, the A3 to get the booster. So if you look at the disparity in terms of those who receive the primary vaccine series and that who receive the booster, is still a long way. For example, in the A2 population, almost 6 million already received the primary vaccine series, but those who received the booster dose are less than 2 million. Same as that in the A3, wherein you have almost like 9 million who received the primary vaccine series, but only around 2 million who received the booster doses. Same also with the frontline essential sectors, wherein 19 million received the 2 doses, but only 3 million received the booster dose. So there's a lot of the work to do, especially for booster doses, because receiving this third dose will be crucial and the indicator of the possibility of incoming surge and spike of cases. Not only that vaccine can prevent illness and death, but it can also have an impact on long COVID. So long COVID has been known to be a major cause of morbidity and mortality after recovery against COVID. And in this new data coming from the UK Health Security Agency, they found out that for those who were vaccinated and yet developed COVID, their likelihood to develop the symptoms due to long COVID is lower compared to those who are unvaccinated. And in fact, long COVID can be as longer as 3 to 4 months. And in this data, for those who still develop long COVID symptoms and are vaccinated, develop less severe form of long COVID symptoms compared to those unvaccinated. And there are more vaccinated than unvaccinated that had remission of all long COVID symptoms. Okay, so again, the advantage, the benefit really is not only the benefit of vaccination is not only prevention of death, prevention of getting the infection, but also most important is also prevention of the long COVID symptoms, lowering the mortality, morbidity of this particular complication. The other part here is that the government is also expanding the immunization recommendation, not only to the adult 18 years old and above, but also to 5 to 11 and the 12 to 17, because we know that this population are also vulnerable as that as the elderly. And when you have this population being vaccinated, their chance also of risk of developing complications, including getting the infection, since we are also targeting that this population will also be going face to face in their school, then we need to impart to them the importance of protection. There are talks now that fourth dose of COVID vaccine is needed, specifically for the A1, the healthcare workers, those with comorbidities, and those with or who are immunocompromised. Okay, and this was based on the data coming from Israel. Okay, where they are using the mRNA vaccine that giving a fourth dose not only retained the protection, especially against Delta and Omicron, as higher as that compared to giving the first booster, but also the eightfold increase, okay, in the neutralizing antibody against Omicron is enough basis that protecting this population against severe disease when receiving the second booster will prevent also severe infection. And likewise, in their data, they found out that giving the fourth dose to individuals like the 60 years old and above and those who are immune compromised prevented the risk to develop severe disease, okay, which was very instrumental in their setting in limiting the burden of hospitalization during the fast and widespread of this Omicron surge. Okay, so the rate of severe illness was lower by a factor of 0.3, and although this is a modest protection, but for a population with a higher risk of getting hospitalized and getting higher mortality, like the 60 years old and immunocompromised, I think these are very important strategic protection, adding a second booster in order to maintain the viability of our healthcare utilization. Now, we need to understand also and explain that even with vaccination, even with booster, there will always be what we call escape immunity and higher, there's a likelihood of another infection. And basically, when you look at vaccine efficacy, it will always be affected by the host, like age and risk group and immune status, wherein elderly population, higher risk of getting hospitalized, even if they have been vaccinated. Specific risk group, like those patients who are with comorbidities and those who are immunocompromised, higher risk also of getting severe infection, even if they're vaccinated, but they're in a better position to fight the infection with vaccination rather than no vaccine at all. The viral factors is also a factor. Why? Because of if the mutation is so heavy enough to evade protection, then chances are we need a dose of vaccine to increase the protection. And of course, there are vaccine factors that can also affect vaccine efficacy. Now, the other arm of limiting illness and death is the presence now of treatment in the form of antiviral and monoclonal antibodies, including immunomodulators for those who are hospitalized and to prevent them, lower risk of mortality and lower risk of requiring mechanical ventilator. Okay? And these are in the form of your tocilizumab, baricitinib, and steroids. Okay, so these are treatments that so far has been proven to be effective, and these are the important aspect of the intervention that we need to have in our hospitals. And this is how bad if you have comorbidities and age, higher or elderly, higher risk of death, higher risk of hospitalization. And basically why I'm showing this one, because if we talk about antivirals and monoclonal antibodies, when this population still develop infection despite vaccination, they are the person that should be receiving these antiviral agents and monoclonal antibodies, so to prevent them from getting hospitalized. So in a report last January 2022 in the US, wherein they already have vaccinated a lot of these uh, patients with comorbid conditions, there are still risk factors that even with vaccination, the risk of developing severe COVID is high. And these are patients whose age is 65 years and above, those who are immunocompromised, those with diabetes, those with chronic kidney, cardiac, pulmonary, neurologic, and liver disease. So the higher the number of comorbidities, the higher is the risk of death, even if you are fully vaccinated. So in the current stage of COVID-19 therapeutics, I would like to mention here specific drugs that has been proven and effective even against an Omicron variant. And these are the four: your monoclonal antibodies, texagevimab, selgavimab, and then of course molnupiravir, Paxlovid antivirals, and that of remdesivir. Okay, so first is your monoclonal antibody in the form of your texagevimab and selgevimab. No? So this is a dual monoclonal antibody that is manufactured by Astra. So the basis for an FDA approval of a pre-exposure prophylaxis for this monoclonal antibody was this proven trial, wherein they enrolled patients or enrolled individuals who are 18 years and above with a higher risk of inadequate response to vaccination, and then giving them these monoclonal antibodies for a total of 6 months. Okay, and then compare it with placebo and look at among the population that are given the placebo and the drug or the monoclonal antibodies, how many of them develop COVID. So they found out that for those in the monoclonal antibody arm, it was reducing 77% of the symptomatic infection during the first 3-month interim result. And then after 6 months, 83% reduction in symptomatic infection. So that's quite a very good reduction in symptom with this monoclonal antibody. So this is just a single monoclonal antibody, but you notice that the protection is at least 6 months. No cases or in the treatment arm died, and the adverse events are almost equal compared to that of the placebo. So more or less, it's safe and tolerable. Now we go to the updates on antiviral. First among this is your molnupiravir, and the current recommendation is giving it to mild to moderate cases with high risk for progression to severe disease, or for those who have no other treatment options. So this is a drug that can only be given in 18 years old and above. It cannot be given for those who are pregnant, and it cannot be given also to children. Now, In this data, you'll notice that when they did the clinical trial on molnupiravir compared to that of the placebo, there was really a reduction. So it prevented severe COVID in 30% of those who are in the treatment arm compared to the placebo arm. Okay, and what is also important in this particular study, they found out that during the third day and fifth day of taking molnupiravir, there was a significant decrease to half in terms of the viral load of the SARS-CoV-2. So the implication then is that because of its antiviral effect, it can easily decrease the viral load, increase the recovery rate, and at the same time decrease the risk of transmitting the infection. The next among this antiviral drug is your nalmefene ritonavir combination. So this is a combination of the nalmefene, which is the active molecule that will also decrease and decrease the replication of the virus, while your ritonavir will allow nalmefene to stay in the serum for a longer period of time. Okay, so this drug is also like your molnupiravir, can be given to those with mild to moderate COVID-19 with high risk for progression to severe disease, and it should be initiated within 5 days of symptom onset. Okay, so just like your molnupiravir, you have to take that opportunity that when you're giving this drug, the patient is within 5 days upon the onset of symptoms. So this is the viral phase, so that you will maximize the effectiveness of this drug. Now, because of the drug-to-drug interactions wherein your ritonavir will also inhibit the CYP450, an enzyme that is also important in the metabolism of other drugs, then you have to look at specific drugs that will have a drug-to-drug interaction so that it will prevent you from getting toxicity of those drugs or toxicity related with ritonavir. The other thing here versus that of molnupiravir, here you need to know the estimated GFR, so that if the GFR is more than 60, then the usual dosage of your nalmefene is 300 milligram of your nalmefene and 100 milligram of your ritonavir every 12 hours for 5 days. So that means twice a day. But if the GFR is less than 60 but more than 30, then you have to have the nalmefene component of the tablet and then continue with the 100 milligram ritonavir to be given again twice a day for 5 days. Now, in the event that your patient has an eGFR of less than 30, then this drug is not recommended. So based on the clinical trial, this drug was able to reduce the risk of those who were given the drug compared to placebo to be admitted to the hospital or death in 89% if the drug is given within 3 days from onset of symptom. And if it is also given within 5 days from onset of symptom, the reduction is still very high at 88%. And just like your molnupiravir, it was able to decrease the viral load compared to the placebo. But here, the viral load decrease is quite significant, which is tenfold during day 5. So when you have a patient with a very decreased viral load, then higher chance that this patient will not develop severe infection. So here, these are the safety and adverse event and the most common side effect that were observed among patients on nalmefene ritonavir were impaired sense of taste, diarrhea, high blood pressure, and muscle ache. Now, the last among this antiviral is remdesivir, and I think most of us are familiar with this. No? And we knew that remdesivir has been very active and has been very helpful for our patients who were admitted before with moderate to severe COVID because of faster resolution of symptoms and lower mortality, although it did not affect significantly in terms of mortality, but the time to recovery, resolution of symptoms was significant enough compared to those who did not receive remdesivir. But in this new data, among those with mild to moderate COVID, this has been recommended for those with these particular symptoms in preventing them to develop severe COVID. And just like your molnupiravir, your Paxlovid, this drug has been proven to be effective in this population at high risk for progression to severe disease, that they will not progress to severe disease even if they have mild to moderate COVID. Okay, so in this placebo-controlled trial, in the remdesivir arm compared to the placebo arm, they found out that there was an 87% lower risk of hospitalization or death compared to placebo. So in a way, these are very important antivirals that we all have now in our hands. That anytime if we have high risk patients, patients who are diabetic, patients who are obese, patients who are elderly, 60 years old and above, then we have to have in mind that there are drugs that can prevent them from getting the more severe COVID. The other aspect of dealing with this with the new normal is always think of that when we are in this stage of the infection is still with us. The virus is still with us. So we need to become part of our daily life. If we are symptomatic, we need to be testing ourselves. We need to do the test in order to know if it's COVID so that we can isolate ourselves. We need to keep our workplaces very safe, okay? Especially the workplaces, the schools, including recreation and entertainment locales. And then we have to have a rapid response to transmission hotspots in the event that there are cases that will be reported. So in a way, we can deal with the virus as long as there will be slowing down of the transmission, that it will not cause surge. Then these are the things that we need to be in place in the workplace, policies that will diminish the risk of more transmission and more symptomatic. Okay, so currently most workplaces are already what we call COVID resilient. Okay, through policies and practices that has been implemented in order for these workplaces to be conducive to working with a lower risk of transmitting the infection. And that also include infrastructure improvement, okay? Reconfiguring workspaces to enable physical distance, improving airflow, and in fact, also the use of HEPA filters has been part of this intervention, okay? And of course, we encourage these workplaces to have policies on case investigation and contact tracing, especially for those of these workplaces will have cases. So in part, I'll just show you here some of the safe work environment plan. Okay, this is coming from the WHO Workplace Action Policy against COVID. Okay, always ensure sufficient supply in your workplaces for face masks, for hand hygiene supply, and then ensure also sufficient resources, identify and include safety and health expertise, training of workers, especially reopening protocols before reopening the workplace, and then conduct symptom survey of workers every now and then regularly. And in the event that you are still not prepared, you can establish what we call rotational schedules to decrease workplace density. So I'll end my topic here by looking at what are the important roles to play and how we should play this. No? So this is a multidisciplinary approach, multi-sectoral approach that does not only involve the government, this should also involve the employers, the health system, and of course, the individual. The government will continue to build consensus on goals, communicate to the public, and transparency is also very important in terms of case reporting and setting up tracking these metrics in order for us to get a hold of what is currently our situation. Okay, the employers, for those who are in the workplaces, should have their role elevated. They have to have policies in the workplace to prevent the surge of cases, help their employees think through the changes. Okay, and this should be something that is very promotive and enabling. The health system forms an important part. Okay, we the healthcare workers should always reserve rooms for COVID so that any inevitable outbreaks and surges, then the healthcare system will not break down. And of course, we as an individual, we have to adopt new behaviors. Okay, for us to adapt to this new normal, we need to have a very good mindset of protecting ourselves every day, not to be complacent with everything. Get the boosters if you haven't had the boosters. Okay, always wear face masks, especially in the workplace. As much as possible, we discourage unwarranted, okay, unnecessary gatherings. Okay, and that's something that we always inculcate in our daily life. Okay, so I think with that, these are the things that very important in this setting of what we call the new normal. Thank you very much for your kind attention.
Okay, thank you very much, Dr. Solante, for that very updated lecture. So, unfortunately po, hindi makakasama sa atin ngayon si Dr. Solante because of another engagement. Okay, but we are very fortunate kasi nandito pa po si Dr. Dr. Ella Santos. I hope she can entertain. So let me read muna yung mga comments for Dr. Santos. So yung very clear and informative lecture from Dr. Grace de los Santos. So thank you for pointing out that no benefit of fish oil to increase HDL in insulin-resistant individuals. So if you have any questions po para kay Doktora, please type it in our chat box. Doktora, still here po? Sir Julius?
Yes, Doctor. I'll check po. Andyan pa ako, nandito pa po.
Pa-highlight na lang si Doc. There's a question, Doc, with regards to sa muscle pain when using mga statins po. With Pitator, na-observe po ba ito sa kanila? Kasi di ba yung mga statins pwedeng mag-cause ng mga muscle pain? Hello, Doc.
Naka-mute siya.
Hindi ko makita dito si Doc.
Nasa frame 1 siya eh. Nandyan siya.
Oo nga eh. Frame 1. Yun. So, very significant yung lectures natin for this evening. Okay, so lahat po ba kayo nakapag-booster na? Ha?
Yes.
Wala pa, no?
Yes.
Yung mga ibang patients natin, ayaw na magpa-booster. Kaya siguro makita niyo yung data na present ni Doc. Basta nakatapos na ng second dose, ayaw na nila pa-booster. Kaya mababa siguro. Kasi baka akala nila protected na sila.
Sa NCR yata mataas naman eh.
Sa mga health workers, yun.
Hindi, sa amin sa UP, 100% taas. Usually sa mga probinsya yata mababa. Kasi natatakot sila sa mga side effect na naririnig nila sa first booster. Ayan si Ma'am Grace.
Tsaka pagka nag-booster pa sila uli, natatakot sila. So may isa pang comment. So, yes,
Ma'am,
ma'am.
pwede po itanong kay Dr. Solante kung when will be the second booster? How long after the first booster ang second booster na nire-recommend nila?
Second booster?
Diba
Yung
sinabi na
primary
after the
series
fourth
po?
infection? O,
Naaral pa nila, ma'am eh.
ay, di pa alam. So,
Hindi pa, ma'am. Pero
recommended.
ang
Wala
sabi
pa,
ng virologist sa amin, ma'am, after 3 months. Kaya lang inaaral pa, ma'am, nila. Wala pang guidelines.
Okay.
Yung sa atin, sa booster natin, napaaga eh, di ba?
Yeah.
Pero yung nag-booster ako, tumaas ng aking antibody, 4,000 plus, pero nagka-COVID ako.
Okay. So, hindi na din natin maka-join si Dr. Santos sa atin. Ma'am, siguro ma'am, ikaw ma'am, you're also the authority to si Mama Grace with regards to pitabastatin.
Oo.
Ma'am.
Oh.
Kasi
Yung
ma'am, meron
sa
akong
muscle pain.
Oo. Kasi ma'am, meron akong mild fibromyalgia with rosuvastatin. Talagang masakit, ma'am eh. Yung pita kaya, ma'am, meron. Natatakot na akong itry ulit
Meron din siya. Parang common naman siya. Pero doon sa studies nila, mas less. Much less. Saka ang recommendation ng mga expert, yung makikinig ko ng lecture, is you lower the dose.
Low dose. Opo. O, sige. Thank you, ma'am.
Pero check, pag hindi tumaas ang creatine kinase. Pero pag tumaas ang creatine kinase, you have to observe. Kasi hindi naman lahat ng masakit ay tataas ang creatine kinase.
Okay.
Thank you po, ma'am. Ma'am, may isa pa akong tanong sa'yo kasi tungkol doon sa fish oil. Di ba, mostly pag nakakawa tayo mga patients dito, may kamag-anak sa ibang bansa, padala ng mga fish oil. O, di syempre, inumin naman nila yun. Okay, tatanong din sa atin. Yung effect po ba ng fish oil, is it dose dependent?
Hindi, ang ano niya is, ang explanation, padalas ko na narinig kay Ella. Ang ano niya is, ang insulin resistant, walang kwenta. Kasi ngayong gabi, very clear siya eh. Yung bumabalik dahil sa hepatic lipase.
Ang cycle siya. No?
Imbis na yung HDL ang tumataas, LDL ang tumataas sa mga insulin resistant. Pero ang ating fish oil kasi is EPA plus DHA, di ba? Lahat sila EPA plus DHA. Pero yung pure EPA, yun lang ang effective na magpataas. Pero sa Amerika lang meron at sobrang mahal. Yun ang sabi niya.
Oo nga po. Medyo mahal. Meron bang food, ma'am? Ano, ma'am?
Yung pure EPA ang maganda, pero hindi yung may kasamang DHA.
If I may, Dan.
Ma'am, yes po. Yes po.
If I may add, yes, ang tanong mo, is it dose dependent? Yes. Kasi in some of the triglyceride studies...
Hi, sir. Sorry. I was told that there was no Q&A.
Yes, ma'am. It's all right. Pasensya na nabigla.
Oh, no problem. Sorry. I'll go through it po. So, all right.
Meron mga questions kasi with regards to the fish oil.
Hi, hello. Sorry about that. So, thank you for pointing out no benefit of fish oil to increase HDL in insulin-resistant individual. Thank you po. We always try to remind everyone. How low can you go? Low as far as LDL is concerned. We now have new drugs. These are the injectables po. We are currently with an international clinical trial that we're excited about. This is called a PCSK9 inhibitor that's only injected twice a year. About a year and a half ago, PCSK9 inhibitor was launched that we inject every 2 weeks. Ito po yung mga very high-risk patients. The lowest I've gotten with LDL po is 9. This patient had a stroke at an LDL of 45. So we had to lower his LDL cholesterol. He's actually a doctor doing very well, and we've kept his LDL cholesterol at 9. So if you ask me po how low LDL can go, I do want to tell you I'm very confident with even going down single digits. So ito pong bagong injectable, it looks like we are targeting LDL cholesterols that are 70% from baseline. So that means mga 20-25 milligrams per deciliter po. So thank you po for that question. What's the reason why pitavastatin has the lowest incidence of new onset diabetes among statins? So what's great about this new statin po, understand that pitavastatin was developed in Asia, kaya po ang dami niyang clinical trials among Asians. And the reason why it comes into favor po is the fact that it undergoes its own pathway, glucuronidation. So it doesn't go through cytochrome P450. So alam po natin, ang cytochrome P450, lahat ng ibang gamot goes through it. Ketoconazole, miconazole, all your other medications, verapamil. So because of it, maraming limitations ang cytochrome P450 drugs like atorvastatin, simvastatin. What's great po about pitavastatin is it has its own pathway. So because of it, it doesn't have drug-drug interactions with the common drugs that we give for very high-risk individuals. The antifungals that we give to patients, those with HIV, their heart, yan po, lahat yan nagda-drug-drug interaction. So pitavastatin beautifully has its own pathway. So because of it, it has lesser of the adverse effects. Statin myopathy, new onset diabetes, and that slight increase in liver function tests that we see when we place on patients on statins that or the other cytochrome P450 metabolism. So that's the reason po why it has the lowest incidence of new onset diabetes. There's lots of
Yes.
Is there an indication for combination of fenofibrate and statin? Oh, yes po. So, ngayon po, meron po tayong mga in the market na combination, no? Single pill combination ng fenofibrate at simvastatin. So, ito pa lang po kasi yung available ngayon. And in those patients where you've already gotten to goal LDL and their triglycerides remain high, above 500, then you can actually combine this particular statin fenofibrate combination. But you have to target LDL cholesterol first. If the LDL is targeted already at goal and the triglycerides are above 500, then yes po, there is a benefit to this single pill combination therapy with fenofibrate and statin. Thank you po.
Yes, Doc, another question.
Okay,
when do you use sinong patient?
2 milligrams and 4 milligrams. So understand that this is a moderate intensity statin dose. It has a 42% reduction with the 2 milligram and the 4 milligram has a 47%. And again, when we take a look at Asians, dahil ang dami pong clinical trials with Asians in the pitavastatin group, the real CAD was actually CAD patients, very high-risk individuals, where they found that Asians have a higher tolerance, ibig sabihin po, mas tumataas, mas malaki yung reduction ng LDL cholesterol nila. We were actually part of a clinical trial in the Philippines called the genomic study, where we're looking to see patients with statin therapy and we're finding hyper responders. So these are patients po who, with the same dose of, for example, pitavastatin, have a more than 47% reduction in LDL. Umaabot na pong above 50%. Kasi nga siguro Asians are frailer, we have thinner body mass, so because of it, we respond more to statin therapy at the same dose as our Caucasian counterparts with bigger body masses. So because of it, when we use 2 milligrams and 4 milligrams, understand that this still falls into moderate intensity statin therapy, but the 4 milligram may actually surpass the 47% and go into that higher intensity, particularly in Asians. So it can be used in patients with CAD. Thank you.
Yes, thank you. Doc, we have patients na meron na mga end-stage renal disease o kaya ongoing na yung dialysis. Diba may, anong recommendation natin on the use of statins, particularly itong pitavastatin?
Great question po, sir. So, ulit, pagka pupunta tayo sa renal disease patients, we have the KDIGO guidelines. And the KDIGO guidelines, if you take a look po, they classify patients into those who are pre-dialytic and those who are already dialytic. I want you to understand that the value of that po kasi is when you're on dialysis, yung atherosclerosis po is not so much cholesterol deposition. It is arteriolosclerosis. Ibig sabihin po, yung dialysate, pinapaliit niya yung lumen sa arteries, kaya po yung nangyayari sa mga pasyente with dialysis, iba po, hindi po siya cholesterol plaque deposition lang. So ang recommendation ng KDIGO, kung hindi ka nakastatin bago ka i-dialyze, hindi indication to start on statin therapy, just the fact that you are now going to be on dialysis. So, pag hindi pa nakastatin, bago dialysis, tapos ngayon na-dialyze ka na, hindi nyo po isa-start. But if you were on statin therapy prior to dialysis and then now you're being dialyzed, then you continue statin therapy. Having said that, in those patients stage 3 to 5, na hindi pa po dinadialyze, ang recommendation po, marami pong clinical trials using statin-ezetimibe combination. So we have the SHARP study, the Aurora study, which showed that in these patients, this combination fares well in terms of translation to outcomes. But these were the older statins. So now we have a new statin called pitavastatin. And again, because it doesn't go through cytochrome P450, where patients with CKD we know are on 10 other drugs, we know that the drug-drug interaction is minimized. So ang maganda po, in patients with CKD, may mga Asian studies na po using pitavastatin, and it looks like this is a great alternative for statin therapy in patients with CKD. Thank you po.
So do you need to adjust the dose kung nakastatin na sila?
So, great question po. Again, because this is through glucuronidation, you do not need to adjust the dose. So, marami pong mga favorite po namin yan. So, we have patients that come into clinic na may indication po for 80 milligrams of atorvastatin. Again, because if you have a high-risk individual, dapat ang LDL cholesterol goal nila less than 55. Pagka binabaan niyo po, hindi sila aabot dun sa LDL goal na less than 55. So what a lot of physicians do, and I don't know po if this is a knee-jerk reaction, they downgrade the 80 milligram to 40 milligrams. There is no recommendation po to downgrade if the primary indication is coronary artery disease. So, in secondary prevention, na stroke na heart attack na po, targetin nyo pa rin po ang LDL below 55 milligrams per deciliter. With atorvastatin, there is no dose adjustment. CKD patients can tolerate high-intensity statin therapy. So again, whether you need high-intensity statin therapy with ROSU 40, 2040, ATOR 4080, patients with CKD can tolerate it. Of course, we do know that sometimes patients on rosuvastatin, their creatinine can slightly increase. So these are the things that we just have to monitor closely. Pitavastatin becomes an option. If there is a need for higher intensity pitavastatin, then we keep them on 4 milligrams with no dose adjustment for CKD because the primary drive for dosing is going to be the indication for their risk. So kung high risk po, 4 milligrams of pitavastatin.
I think that's a follow-up question, yung kung nagda-dialysis na, tapos syempre alam natin kapag mga CKD patient, cardiac ang problema niyan. So when they develop MI,
so
mag-start ba tayo ng statin?
So again, one of the most common causes of mortality in CKD patients on dialysis will of course be myocardial infarction. So in these particular patients, again, what prevails po is the fact that these patients have to be on high intensity statin therapy. So we only have 2 high intensity statin therapies. That's ATOR 4080, that's ROSU 2040. We have a new armamentarium, and that's this pitavastatin, where the 47% may actually reach up to more than 50% in Asian patients. And of course, we know that the ESC is now making recommendations for combination therapy, where ezetimibe in combination with any other statin, as long as it can be used to get your patients to goal, can be administered if even at the current dose of your patient, meron na kasi siyang side effects, pinupulikat na siya, so hindi mo na mataas, pwede niyo pong ilagay yung ezetimibe. Kasi meron po tayong Improve It study na nagpakita that in the background of statin therapy, when you place ezetimibe, may additional 6% reduction for cardiovascular outcomes in the background of LDL that is controlled with statin therapy. Thank you po.
Okay, thank you, Doc. Earlier, pinag-uusapan namin yung fish oil kasi diba, most of our patients may mga kamag-anak sa ibang bansa, and then pagdating nila, may malalaki silang mga containers of fish oil. So, natatanong din namin kung yung dose ba ng fish oil would matter o dose dependent ba yung effect niya pagka binigyan pa
ko lang,
natin?
sir. There's a new study that recently came out. It's called the Reduce It trial. So, yung fish oil po, matagal na po namin gustong maging positive yung trial na yan. Particularly because fish oil can reduce triglyceride significantly. So this is its primary purpose. So because we know that triglyceride-rich particles can cause atherosclerosis, di ba po nakikita natin in our insulin-resistant patients, itong mga triglyceride-rich particles, these can also cause atherosclerosis. We've really been vying for omega fatty acids, fish oil, to be a positive trial. Unfortunately, lahat po ng omega fatty acid trials, pag titingnan niyo po, negative siya. And recently, it came to light that the reason why omega fatty acid trials have been negative is because the omega fatty acids that we make before were combinations of EPA and DHA. At ang nakita po nila na ito po palang DHA nakakataas ng LDL cholesterol. So, yung EPA na maganda, na-negate yung effect pagka kinumbinan mo siya ng DHA. Recently, nagkaroon po ng omega fatty acid na pure EPA. Ito pong pure EPA na to, ang tawag po sa kanya Vascepa. It's actually available in the United States. A few years back, there was a clinical trial called the JELIS trial, which was done in Japan, which also had good outcomes. Pure EPA din po ito. So ang nakita nila na itong pure EPA na ito may cardiovascular benefit. So yung Reduce It trial, ang ginawa po nila, these were patients already on statin therapy, still with elevated triglycerides, where omega fatty acid, Vascepa, or pure EPA was given. And it translated into reduction of stroke and heart attack. So for the first time, we have an indication for omega fatty acid. But understand that the omega fatty acid that showed cardiovascular outcomes reduction was pure EPA. Not available in Southeast Asia. Hindi po siya yung GNC, Healthy Options, Costco na nakukuha natin, Sam's Club, na pagtitingnan niyo po, may EPA, tsaka may DHA. So basta may DHA po na nandun, it negates the effect of the EPA. So unless what you have is pure EPA, and understand po, the pure EPA is the formulation that is prescription drug in the US. Marami na po kasing mga pasyenteng bumabalik from the US, galing sa Sam's Club, may pure EPA.
Yes.
Pero kung babasahin niyo po, sir, may DHA pa po talaga. And that's why it should be the prescription drug called Vascepa. Here, as long as patients are on statin therapy, ibig sabihin po, hindi pwedeng on its own. Kailangan patients are on statin therapy. The LDL cholesterol is already at goal, but the triglycerides are still between 150 to 499, giving this omega fatty acid, which is pure EPA, can give you significant reduction in heart attacks or stroke. Thank you.
Yeah, may follow-up doc na ano, yung sobra ba?
Apo, yes, no problem, sir. So is too much fish oil bad? So that's a great question. So it really depends po on what the indication is. I want you to appreciate that in the Philippines po kasi, favorite po ng ibang physicians to give fish oil to increase HDL, no? So, ang fish oil po, hindi po yan ang primary purpose niya. Ang primary purpose niya to lower triglycerides. Sobrang galing po ng fish oil to lower triglycerides. So, yung mga patients po natin with familial hypertriglyceridemia, bigyan niyo po ng fish oil yan. Within a week, kalahati ang kanilang triglycerides. But these are those with triglycerides above 500. So, ang problema po with these fish oils, although they can elevate HDL, this is not its indication. It should be to lower triglycerides. And the reason is because nakita po natin in clinical trials, yung mga mababang HDL, nung binigyan po sila ng omega fatty acids, kahit na tumaas yung kanilang HDL, yung type of HDL na nai-increase with intake of fish oil, yung mga tamad na HDL. So si HDL po kasi, ang epekto ni HDL para po yung basurero. What HDL does is it goes to your body, it removes LDL, and it excretes it. The problem is, when you increase HDL by giving patients fish oil, it doesn't necessarily increase yung mga basurero na masipag. So parang ang lumalabas, basurero na tamad. So kahit na tumataas ang HDL po nila, sir, hindi naman sila nagtatranslate into cardiovascular outcomes. Kaya po meron pong mga gamot na tinanggal na po sa market. Anacetrapib, torcetrapib, kasi po yung HDL umakyat to 500 pero wala namang reduction of stroke and heart attack. So now we're looking at HDL functionality. So wala nang purpose yung number of HDL. Ang may purpose yung functional HDL. So you and I, sir, can have the same HDL, 50. Pero kung lahat ng 50 ko tamad, tas lahat ng 50 mo na HDL masipag, hindi po ako magkaka-reduction in stroke or heart attack. So now, in lipidology, we're looking to develop markers where we can measure HDL functionality. And until we can measure HDL functionality, we do not recommend increasing HDL in low HDL patients. Alam natin may risk pagka mababa ang HDL, pero wala pa pong therapy that increases HDL that has translated into reduction of events. So outside of stopping smoking, exercise to increase HDL, wala pong gamot kaming nire-recommend in lipidology to increase your HDL until we can measure functionality. So is yes.
Yes, I agree ako doon na lagi yung sinasabi sa amin with si Tatay Rick Fernando. So he always, the only thing that will increase your HDL is exercise. So wala naman din siyang sinabing gamot.
Tapos is too much fish oil bad? Again, if the fish oil you're getting is taba ng tiyan ng bangus, salmon, then no, absolutely not. You can eat as much of it because your body can process it. But again, yung mga fish oil capsules po, we don't particularly know the benefit outside of triglyceride reduction. Thank you.
Yes. Tapos iba-iba pa yung manufacturing. There is also, hindi lang fish oil, pati yung seal oil.
Dami na nga, krill oil, seal oil. So we get a lot of questions, no? So I always tell them po, if the purpose is to improve your skin, to make your hair better, then by all means take it. But if you're going to use it therapeutically for HDL or triglycerides, again, stick po to the prescription ones. So even in clinical trials, 1 fish oil a day. Ito po yung favorite ng mga Pilipino, di ba? Isang fish oil a day. Understand that when you take fish oil at the wrong dose, again, because of the DHA, it can actually start elevating LDL cholesterol. So my recommendation is instead of spending on fish oil, which we don't know the benefit of, bumili po kayo ng bangus na mataba ang tiyan, mag-salmon kayo, kumain ng sashimi because it's the fish oil that comes naturally that actually has greater benefit.
Hello, Doc, ilang kilo ba na kaya lang namin kainin?
Sir, taga Nabotas po yung asawa ko. So, sasabihin ko sa'yo, maraming kilo po talaga yung nakakain namin per day.
Kaya nga, para tumaas, o para mag-improve
Pero
siya,
para
baka
sa buhok,
marami.
di ba, sir? Tsaka sa balat, fish oil.
Yeah.
So, importante yon. Yes, sir.
Ma'am, may mga additional pa tayo.
Okay,
Nakakatuwa.
sure.
So, thank you. So,
LDL.
go for LDL for patients
So,
with familial hypercholesterolemia.
We love po that you're asking. So as part of PLAS right now, we actually just met with the UP technical group and they are creating a website for us so that we can now systematize and recruit patients for familial hypercholesterolemia, hoping that we can have a database for FH in the Philippines so that all physicians that have referrals for familial hypercholesterolemia, we can actually have one database and we can review what types of patients we're seeing. So pagka po FH patients, ito po yung na-identify natin with genetic dyslipidemia. Ang goal LDL po natin for them, 70, basta FH po sila. Pero pag FH po sila with one risk factor, FH na, tapos may diabetes pa, 55 na po ang recommendation. So pareho na po as patients with coronary artery disease. Again, because these are higher risk individuals. So FH alone, walang risk factors na iba, hypertension, diabetes, premature, carotid artery disease, peripheral arterial occlusive disease, 70. Pero once meron pa po silang isang risk factor lang, 55 na po ang goal LDL nila. How do you know if a patient has familial hypercholesterolemia? So meron po sa ating 2020 clinical practice guidelines, meron po tayong chart doon. So it's called the Dutch Lipid Network criteria where you just count off po the points. Pagka po meron pong 3 to 5 probable, 5 to 8 possible, more than 8 po, these are definite familial hypercholesterolemia. Ang maganda pa po doon, history, physical exam, tsaka LDL po nila, kaya nyo na pong ma-diagnose. Tama,
Yes.
Sir Arcus, San Thomas, absolutely.
I think it was
alam
discussed, di ba, yung sa ano natin, yung sa PHX.
Yes, sir, absolutely.
Yung recommendation siguro soon, pag nilabas na rin.
Apo, excited na po tayo dyan sa PHEX na yan na ginagawa namin, sir.
So, any more po? Naku, nakakatawa naman na-invite natin si Dr. Santos. So, palakpakan po natin siya.
Thank you very
much.
Always
So
a pleasure po.
We really appreciate your presence with us. So, again, pakawalan ka na namin, Doc. So, we would like to thank you.
Sir.
Siguro, pa-picture tayo kay Doc. So, kung ano po, before we end, please open your camera po. Open lang po yung camera so we can have a group picture with Dr. Santos.
Good evening.
Lynn?
Okay po.
Yan ang mga things na magagawa ng hard life na hindi kayang gawin ng soft life. However,
Okay po. 1, 2, 3. Okay. Picture pa po ulit. Wait lang po. Okay. 1, 2, 3. Thank you po.
Thank you.
Thank you,
Dr.
sir.
Santos.
Thank you.
Thank you,
Good
Ella.
night.
Bye.
Thank you again sa OEP for this wonderful meeting. So for next month, okay, so on April 30, 2022, same time. So ang topic naman natin, the next slide. So next month naman po, we'll have a pharmacy ME grant from glorious Dexamandaya with Dr. Baltimore and Dr. Marcy Cruz. And we are again fortunate to have the EASD updates to be given by Dr. Augusto Litonwa with our moderator, Kuya Elwin Fernandez. Okay? So thank you, Dr. Chuba. Thank you po sa lahat ng nag-participate. And stay safe, lalo na po dyan sa mga taga Batangas na kasama natin. Again, thank you po sa OEP. Thank you, Sir Flo. Thanks, Sir Julius. At
Welcome,
saka yung sa
Doc.
mga kasama natin from OEP.